Welcome to the Dermalorian podcast from the Dermatology Education Foundation. The Dermalorian podcast is made possible with support from Johnson & Johnson. A decade and a half ago, there was just one key private equity investor in the dermatology space. Today, there are more than 35, according to the Bundy Group, an M&A advisory firm working in the dermatology space. Speaking recently with Dermatology Times, they reported that nearly $60 billion of capital investment had gone into the dermatology space from 2016 to 2023, and there is no sign of the trend cooling. For dermatology NPs and PAs, the influence of private equity investment can have effects on everything from basic supplies used daily in the clinic to compensation and retirement planning. For a recent Dermalorian webinar, dermatology physician assistant Kara Gooding joined Michelle Sullentrup, CEO of myDermRecruiter, to discuss these very issues. Ms. Gooding has experience with private equity investment across two different practices with two different experiences. She discussed benefits and potential challenges of working for private equity, noting that her recent experience has been a positive one overall. Here's what she had to say.
Typically in a private equity group, you're going to have a little bit of a higher base salary and then incentive-based pay. So oftentimes you're going to have a collections base. So you have this set base pay, so a guarantee, and then also kind of the harder you work, the more money that you collect, the more you're going to be paid. And typically that's what they want. They want you to work harder so that you make more money, and in turn, they also make more money. And oftentimes you have the ability to have 401k profit sharing, equity and ownership. That's, I think, a really small group of APPs that are afforded that opportunity. I feel very, very lucky for that. Also, we all want to be busy, right? The more busy we are, the more money we make. And so that's the ultimate goal. And we want to obviously take great care of our patients. So they are incentivized to schedule you and really keep your schedule very full. Like our office, I think, I swear in our call center, there must be like a red light that goes off on if there's an opening that day, within 2 hours, that spot is filled. So they're very motivated to keep your schedule full. Also, the larger your group is, sort of the better negotiations you can have with payers versus a privately owned practice. So theoretically, for seeing an acne patient where you might be billing a 99213, you may be paid a little bit more in a private equity group for doing that versus in a privately owned practice. And I think one of the great things in our practice, because we are throughout several different states, is we have an incredible network of providers that I can pull from if I need a hair loss expert or I need a cosmetic expert within my group itself here locally. I have a Mohs surgeon, I have a dermatopathologist, a plastic surgeon, all of them within my practice. And so we really don't have to refer anything out of our practice, which is fantastic. We have an app for communication for our group throughout all of the states that we're in. So I can connect with all of the PAs, NPs, or providers in our group. I can also share challenging cases on the app, which is another excellent resource. And then I think the challenge that we all face as APPs is staffing of MAs. It is brutally difficult. And as you know, whether it be a front office person or an MA, if they don't show up on your day, when you're seeing patients and you're in a privately owned practice, that you just are going to have to deal with it. And there's no other people that they can call in. Whereas in our group, because we have so many different practices, we're able to pull in MAs from other offices or front office staff to fill in the gaps when that's needed. And that's been really quite amazing. And then a couple of other things that I think are advantages in our private equity owned group. We have an extensive IT support. So if Emma goes down or our scheduling system goes down, we have IT that we can call immediately. We do have a large call center for patients to call in. So we have our triage that's there. And like I said, scheduling, they really do keep us very, very full. The other thing with being in a large group, we have less administrative burden on our medical assistants. So we have a group of people who basically, they're our pathology team. They're just dedicated, their job is dedicated specifically to calling patients with their results. So that takes that burden off of my MAs and they're able to focus on patient care with me. And again, biologic coordination, we have a specific company now that we utilize. So that's taken that burden off of my MAs as well. There can be career advancement opportunities within the organization. If you want to get into management, that may be something that you can do later on. And then, of course, there's opportunities for advanced learning and training. For example, I wanted to learn how to do intralesional 5FU for squamous cell carcinoma. So I reached out to one of the docs that does it, and he said, yeah, sure, come on over and I'll teach you how to do it. So you have this large network of providers that you can pull from, but also additional training that you can get as well. And then they try to put in different operational efficiencies so that your day runs smoothly. And then some of the, it's not all roses, right? So there's lots of challenges working in a private equity group as well. And I think for me, the toughest thing to grasp is that you're going from personalized medicine with a patient-centric focus, which is certainly what I like to do, and we all do on this call, to more of a focus on revenue generation. And you really have to sometimes, it's difficult, right? You're there for treating the patients, but you're also having this constant pressure of you need to generate revenue as well. And then being in a large group across multiple states, communication can be a challenge. So sometimes you don't even know, like, if there's a problem, who do I call? So that can be, I would say that's probably one of the absolute biggest challenges of private equity and being in a large group. And then you have that financial squeeze. They're trying to be profitable. They eventually want to sell your practice. So there's going to be some cost-cutting measures that can affect your ability to practice medicine, perhaps the way you're used to doing it. Maybe you're using a certain type of blade to do your biopsies with, and all of a sudden they're like, well, sorry, but that one's too expensive. Now you're going to have to use something different. And then, of course, time off is now going to be squeezed. Sometimes in a private practice, they're a little more lenient with that, whereas in private equity, they are pretty hardcore about your time off. And then you're going to oftentimes have performance metrics that they're going to want you to meet. So goals of numbers of patients that you're seeing, things like that. And then sometimes there's protocols or formularies that they want you to follow. And there can be prescribing pressures in certain private equity groups as well, where they may have formularies that say, here, these are these drugs that you have to prescribe, or they may have a pharmacy within the office, because again, that's going to generate more revenue for them, where they say, okay, you can prescribe medications, but it has to be from this specific formulary. And then there can be some streamlining of office policy and procedures that sometimes can be very challenging for the staff as well. There's obviously lots of layers. I always say there's lots of layers of humans within a private equity group. And sometimes it can be both an advantage as well as a challenge as well. But I think the biggest thing when you're going from a private practice to a private equity group overall is just the resistance to change. We all are set in our ways. We have our certain ways that we like to treat patients and products that we like to use. And sometimes when that is changed, it can really create a lot of challenges for us.
We'll turn to compensation considerations after this episode's Dermalorian Derm Decoder. Think you know what unscented on a product label means? Dermatologist Dr. David Cohen says that the term can be misleading and suggests a more meaningful term to recommend.
So picking a good skincare product is very individual, right? And I don't think I'm telling anyone anything they don't already know, right? People always ask me, what's the best sunblock? What's the best moisturizer? It's obviously the one that you like enough that you're going to use. Clearly from my lens, which is always seems to be concerned about hypersensitivity reaction, the allergic patient, the irritated patient, the eczema patient, or the one with inflammatory skin disease, the easy bar is, let's go fragrance-free. Unscented is a term that could be a little tricky. It doesn't have a legal implication because unscented could have masking fragrances in it. But your fragrance-free products, those that have fewer excipients and fewer preservatives in there are best, right? Whether you want to use metal sunblocks like titanium and zinc, I tend to like those a lot. They are a little more challenging from an aesthetic perspective. There are many tinted ones, but sunblocks tend to have a lot of preservatives and often very fragranced. So they can be a challenge on their own, but I still think the benefits of using the sunblock, of using the moisturizer, outweigh any issues of potential allergic contact dermatitis. Obviously, if you're getting itchy or rashy from them, you stop and you pivot. When you can't figure it out is when you patch test.
You are listening to the Dermalorian podcast from the Dermatology Education Foundation. The Dermalorian podcast is made possible with support from Johnson & Johnson. Let's turn to Michelle Sullentrup of myDermRecruiter.com, who has insights on dermatology NPPA compensation in the era of private equity investment.
We want to get you the latest and greatest data on PE compensation trends. So any data that we're providing is all data straight from myDermRecruiter. So these are placements that we've made and data that started in January 1st of this year up through May 1st. So this is real live data for us. And I know that the thing that people want to know the most is all about compensation, and we'll definitely get there quickly. So for us specifically, where are NPs and PAs going? Well, 66% of the placements we've made this year since January 1st have gone to a private equity practice. 33% have been in private practice. That has been about the average for the last few years. So we do see the PE placements going up simply because we do see the average on the base salary going up. So people want to go to that little bit higher base salary. And unlike a private practice, they don't have as much risk in that, right? So they're able to offer sometimes a bigger base salary for you as an NP or PA because it's not as risky for them, right? As say a private practice with one physician owner or just a few. So the averages for private practice offers that we've seen since January 1st has been about $105,000 on the base salary, and then about 28% of collections, which has really gone up over the last few years. So that's good for all of you. The averages for private equity, we've seen higher base salaries and a little bit of a trend of a smaller percentage, still around that 24%, which is good, but that base salary has really kicked up. The average kicked up to $142,500 on a base salary. So you wonder why a lot of people are going to private equity. Some of that is going to be the motivating factor, right? Obviously, if we have a practice that's in South Dakota or is in, maybe like El Paso, Texas, some of these locations that maybe are not as hot and heavy trends to live in or work in, they tend to go higher on those base salaries. They tend to go up on those percentages. So location definitely does matter, just to let you know. There are typical compensation formulas, right? So you all have heard me probably in the past talk about base salary plus productions, collections, all that, and it can be a little confusing. So I want to take a moment to look at our typical compensation formulas. We do talk with lots of NPs and PAs nationally who are telling us they're only getting a base salary. And in dermatology, we don't like to hear that for you. We want you to be part of that person that benefits, right, from those production collection-based bonuses. So, but we do see it commonly when somebody is very early career or they're newer to derm and they're not getting any bonuses at all. They're just getting that base salary. We've had people tell us, my practice said they'll never pay us collections. That's a decision you have to make, right, to see if that's going to be acceptable for you or not in the long term. Also, location does matter again. If you know you can only work within a 60-mile radius and there's one dermatology practice in that area, competition matters, right? So they may feel they don't need to pay that. We think you should get it. We think you should advocate for yourself always, but there are some out there that are just base salary formulas. Then we have obviously what the most common, which is base plus collection-based bonus. So I want to be clear about that. So production is what you bill for the practice, right? Collections is what the practice actually collects for you. So if you bill $1,000 for a procedure or something, right, and the practice is only able to collect $700, you're paid on that $700, not the $1,000. So there's what you produce or bill, and then there's what the cash that comes in the door is the collections. So I want to keep those very separate for you in your mind when you're thinking about these typical compensation formulas. And then obviously there's percentage of collections only, right? So you'll have a lot of even, members at DEF have told me, I just get a straight 30% of collections, or whatever it may be. So that's very common too, that I see that a lot with people who are further along in their career, more experienced, and they're very confident with the patient base they have. So they're willing to just go to straight percentage of collections. And sometimes that can ink up the total collections. If you're on if you're on collections only, you might have been at 25% with a base salary, but since you're going to collections only, they're willing to go up to that 30%. So just keep that in mind. We place most people in private practice and in private equity groups because it's very clear and transparent. But that's what you're looking for in an offer, is to make sure that it's clear and transparent what the percentage of collections is typical for the practice and what you're going to be earning during those first contract terms. And also, I want to know how good my practice I'm going to work at is when it comes to collecting those dollars, right? Because if I'm getting paid, I'm billing all this, I'm getting paid on only what they collect for me. I need to know, how good are you guys at collecting? About what percent is billed that you actually collect so that I know what I'm going to get paid on, right? So do they have delays in collections? Are there problems? That is one of the advantages that Kara talked about with PE groups. They really kind of have that down pat, right? So they're really good at collecting their money, which a private practice may have, less staff, less people to go after that. So just keep that in mind. You do have to know your numbers. You do have to know, what did I collect? What has the practice collect on my behalf of what I've been billing, right? In this quarter, what did I collect all of last year, right? That's how they're calculating your bonus. We better be knowing what those numbers are, right? Ourselves. And how are they reporting that? Especially in the interview stage, how do you report my collections to me? Meaning, what I'm producing, what you're collecting, like, how do I know what dollars are coming in and what aren't? So obviously, super important when you're considering any offer, when you're looking at a private practice offer versus a PE offer, you want the clarity on both sides. If one is not giving you the transparency that you need to understand what you're going to be capable of making, that is definitely a red flag. So you've got to look into that. Anytime we place a candidate, we're really talking to them about what's most important to them. And people are saying that autonomy and that clinical decision-making and daily workflow is important to them. That is less available in PE. You may be more structured. That's okay for some people. For some people, it's not. They want to be able to prioritize personal fulfillment, align with a practice mission or values. I appreciate when somebody comes from a private practice and they've been there for a really long time and they really feel part of the team and part of the family of that clinic. You can still get that with PE because there's a lot of those shops that are converting over to PE. So you just have to pick the right practice environment for you. Obviously, provide a path to long-term growth. Having mentorship, leadership, ownership opportunities would be amazing. And also something that supports the lifestyle goals. So I feel like I do see a lot of people telling me, they're like, oh, I get more paid time off with the PE group. So depends on the doctor you're working for, right? So there's lots of advantages, disadvantages, depending on your goals and what you like. The point is, no one size fits all perfect job, right? So you have to do something that aligns with your season of life, your professional priorities right now.
You can get more information on this topic by watching the archived webinar available at derm-nppA.org/the-dermalorian-webinars. Or learn more about myDermRecruiter.com on the web. Now for this month's Dermalorian Clinical Clip, in which dermatology nurse practitioner Jayme Heim shares insights on managing pediatric patients.
I had 23 years of pediatric experience before coming into derm, and I've been in derm for almost 20 years now. But, just the fact that, when you're treating children, you always have to be so cognizant. You're not just treating a child. You're helping the parent, and parents are very fearful too. And I'm a parent. I'm a grandparent too. And so the pediatric acne, in regards to that, especially from the 6-month to 18-month age, and the fact that it can have severe scarring already at that period of time, and that really it is treated with first clindamycin and, benzoyl peroxide, clindamycin or adapalene, and if really severe, then to going further, such as antibiotics and isotretinoin. So I think that, that's another thing where we need to always be not only cognizant, but we need to not be afraid to treat children and do the right thing. And we're looking also at long term. Nobody wants to have their child grow up with, even as a toddler and having the large pock marks all over their face. We can do better.
In case you missed it, representatives from the insurance industry have pledged to do better when it comes to prior authorization procedures. Read about it on the blog page at dermnppa.org. The Dermalorian podcast is produced for DEF by Physician Resources. Thanks for joining us.